an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.
Perhaps no public health initiative has been more anticipated, debated, and longed for all at once. The rollout for COVID-19 inoculations is underway, if more slowly than anyone wants. Tonight, what's taking so long, and what's going to get the job done? Then, longtime Hamilton Spectator journalist and author Denise Davy is with us on her new book about a woman named Margaret. You may not know her name, but her story of mental illness and homelessness may sadly be all too familiar. It's Tuesday, March 2nd, and that's next on the agenda. Very early in this pandemic, it became clear that the light at the end of the long tunnel was vaccines. Putting that into operational effect, however, has proved to be a much more complicated endeavor. From the race to create effective vaccines in record time, to procurement, and now rollout into the arms of Canadians. None of it can happen fast enough, of course, but let's look back and ahead at the effort. We welcome, as is our custom on this program, we introduce from furthest away to closest to our studio, starting in Vancouver, British Columbia, with Carolyn Collane, Professor and Canada 150 Research Chair in Mathematics at Simon Fraser University. In the nation's capital, Nick Taylor-Vasey, Associate Editor for Maclean's Magazine, and in the provincial capital, Dr. Isaac Bogosh, infectious diseases physician at the University Health Network and a scientist based out of the Toronto General Hospital and the U of T. And Dr. Bogosh, good to see you again. And Carolyn and Nick, good to have you on our program, I think for the first time for both of you. Nick, you've been here before?
I have not. No,
I didn't think so. No. Okay. No, good to have you here. Let's start with a chart. Charts are always very helpful in this regard. Sheldon, you want to bring this up? Thank you. This measures confirmed orders of vaccine doses per person for last year. And Canada is number one. We confirmed a great number of orders per person in the world. Australia comes second, Britain, the United States comes further down, the EU, and so on. This is not obviously the whole story, but it is part of the story, and we will start there. Nick, come on in here and tell us, because back in November, we looked pretty good in terms of vaccine procurement, but now it's early March of 2021, and it's a bit of a different story. How did we become the country with the most procurement in the world?
Well, you had a very busy team of procurement folks in Ottawa, negotiating with all of the leading candidates around the world, and frankly, competing with countries that offered much larger bases of customers. And also continental blocs like the European Union. And they came up with all these different agreements that amounted to almost 400 million vaccine doses, which, as all of your viewers will know, is many more doses than there are Canadians, even when you account for the two-dose nature of so many of these vaccines. So they spent most of the summer negotiating with these companies.
So would you call that kind of the good news part of the story?
I would say that the agreement with Moderna and the agreement with Pfizer were two of the first to be signed with those respective companies around the world. The other agreements came later, and when we start to have debates about where Canada is in line for all these vaccines, I think there's a really good argument that Canada is near the front of the line, if that's even an appropriate way to put it, with Moderna and Pfizer. With the other companies, it's a little less clear because those deals did come a bit later in the process. Okay.
Dr. Isaac Bogosh, let me get you to react to that. The notion that last year, when this was all ramping up, Canada was actually at the, again, an unfortunate expression, but was at the front of the line for countries around the world securing doses. What did you think at the time?
Oh, I thought it was fantastic, given that at that time we don't have the capacity to mass produce or make those vaccines locally at that time. And we were going to be relying on foreign companies in foreign countries to get these vaccines. I think they did the right move by putting together a task force to really bet on potential winners. Remember, this was before we had the results of a lot of the clinical trials. And they ended up putting their money down on several winners, right? Pfizer, Moderna, AstraZeneca, Johnson & Johnson, Novavax. Like, these all ended up being really good vaccines when we saw their phase 3 clinical trial results. I'm sure we'll hear more about what transpired since then, but those are 5 very solid vaccines.
Okay, Professor Cullen, how about from your vantage point? How did we look back in the day?
Yeah, so we did get a little bit of a bad rap in terms of, ordering so many more doses than we have people in the international context when some countries have not had access. But of course, as you heard, we didn't have the results of phase 3 trials at that time, and I think they were doing the best that they could to protect Canadians. Now, I guess it's a question of the contrast between that chart and the relatively slow rollout that we've seen. But I think, of course, securing the doses, will be the cornerstone of our way out of the pandemic. And so it's very natural that they would do that in advance of even having the data about how the vaccines will perform.
Well, you've exactly put us in the direction we want to go next, and that'll take us back to Nick, because, yes, even though we appear to have done very well on procurement compared to other countries around the world, we note that the UK has 20 million vaccines already distributed, 13% of its population in the United States already vaccinated, Canada less than 5% of its people vaccinated. How did we go to doing so well initially to being so poor when it comes to actually getting needles in arms?
Well, I think we've already touched on it a little bit here, and it's largely because we're relying on foreign-produced vaccines. So we have vaccines that are being produced in European plants. And then, of course, there are vaccines being produced in American facilities, but the United States has reserved all of those doses for Americans until the American population is fully vaccinated. So it was the lack of a domestic option, which was the matter of some debate for some time as the country kind of learned what biomanufacturing capacity really is and what it would take to produce these specific vaccines, which are not things you can just sort of put in a queue and have somebody produce in a matter of days. I mean, these are complex products, and so the lack of a domestic option was a huge wake up call, I think, for a lot of Canadians who might have assumed that there were facilities in Canada that could just produce these rather quickly.
Okay, Isaac, talk to us about that part of the story. Why do we not have more domestic production in this country?
Yeah, well, I mean, it's a long story, but the punchline is this really involves years and years of investment to support and maintain that infrastructure. And for years and years and years, we just didn't pump in the money or the requisite support. I think, obviously, this is a health security threat. It's pretty obvious now. You have to be able to produce vaccines locally, basically, given the circumstances that we're all under now. That's abundantly clear. And you've seen a pivot from the federal government. So, for example, there's a plant now in Quebec that's going to be manufacturing the Novavax vaccine. But as to a few points that were made earlier, it's not like we had zero capacity locally. We just had minimal capacity locally. And now there's a clear recognition that that's extremely important. And you're starting to see investment in that. So, for example, the plant in Montreal is going to be producing Novavax, but also there's homegrown small Canadian startups and small Canadian companies that are, developing vaccines and conducting clinical trials. For example, we have a company in Canada that's developing their own mRNA vaccine. So we obviously need to support our local scientists, our local companies, and our local industry to produce these vaccines locally.
Carolyn, why did it back in the day not happen?
So that's, I think that funding picture is part of the story and the investment. And I think, infectious disease researchers would always talk about, what happens when the pandemic comes. We had a flu preparedness plan. We had planning after SARS. But at the end of the day, a major infectious disease event like this one doesn't happen that often. And public health is not that exciting. It's not. Of course, I think it's very exciting, but it's a little harder to sell preventing the problem that you don't have yet than it is to sell solving a huge problem that you do have. So opening a new building or whatever is more direct, more concrete, more tangible. It has a name. It can have a donor with a name on it. Whereas preventing a huge problem that you don't have is a much harder motivation. Hopefully now, recognizing that in the last 2 decades, we've seen SARS, MERS, Ebola virus, Zika virus, H1N1 flu, and now, of course, COVID-19. maybe we will start to think about public health capacity and health security in a more proactive way, and make sure we have those investments. There are companies in the prairies in Alberta. There's Providence Therapeutics. There are companies that mentioned in Quebec that can build this capacity. But I think, we want to make sure vaccines are safe. This isn't something you roll out in a day. You need accreditation. You need the facility to be making exactly the right thing. You need all the protocols in place. So I think that's something on a year time frame or more, not on a 6 weeks time frame. And unfortunately, it's the next 3 to 10 weeks, 3 to 20 weeks where we really need to be vaccinating Canadians to get out of this pandemic if we don't want to keep going with the measures we have for many more months.
Isaac, just follow up on that part of the story, if you would, in as much as, do you think we're now making the right decisions to ensure adequate domestic production in Canada?
Yeah, I think it's a very, very good start. But of course, it's not the end of the story here. So for starters, local companies that are producing vaccines are being supported. I think there could be more to support even before that process starts, and support local scientists and vaccinologists in the preclinical work that's done. And then, of course, you've got to support industry. So, for example, we have the plant in Quebec that will be producing the Novavax vaccine. Certainly that's a start, but of course, it's not the end of the story. We just need to expand on that. But yeah, those are arrows pointing in the right direction. And as Dr. Collane just pointed out as well, we need vaccines in arms now. And of course, supporting those industries and supporting those scientists is a medium-term to long-term plan. Our short-term plan is really still going to be get as many vaccines as we possibly can from foreign companies in foreign countries so that we can vaccinate the local Canadian population.
Okay, we got another chart here. And Nick, I'm going to ask you to take us through this chart. Sheldon, why don't you bring this up? This is new vaccine deliveries in Canada. And I'll describe it in some detail for those listening on podcast who can't see all these bars. But essentially, we go back to last December. And we can see that there is some vaccine being delivered to Canada. We go along to January 10th, January 17th. And then all of a sudden, January 31st, late January, and there's nothing. There is no vaccine delivery coming into Canada at all. Now, in February and towards the end of February, we're getting much more significant doses coming in. But Nick, you got to tell us, what happened in late January where we got nothing at all?
So in mid-January, the federal government said they heard on pretty short notice from Pfizer that the company was retooling its Belgian plant. So that is the plant where Canada is sourcing its vaccine doses from that particular company. They have a plant in Kalamazoo, Michigan, which is just so close to Canada, but of course is wrapped up in the American vaccination effort. So as that plant was retooled to actually produce even more doses in a year, into the billions, the company said it was shutting down slowing down production lines. And that had an impact on every country that was receiving doses from that particular factory. Pfizer said that the distribution would be equitably reduced. Of course, Canada got 0 doses, as your graph shows, pretty starkly. And other European countries never seemed to reach quite that level to the point that there was nothing. But then at the same time, Moderna, the other approved vaccine in Canada, only ships on a every 3 week basis. And so that particular week when Pfizer deliveries went down to 0, Moderna wasn't scheduled to make any deliveries. So their supply was stable, though it also later was reduced a little bit. But that particular week, there was nothing. But as the graph shows, it has started to ramp up, and it will continue to do so well into the future, into the summer.
But I just want to confirm this, Nick. To your knowledge, no other countries anywhere in the world got down to 0, but Canada did.
Not sure if the number is that no other countries got to 0, but the peer countries that we often compare ourselves to in the European Union never seem to get to that point.
Okay. Isaac, the bars on that graph thankfully went up as we went towards the end of February and we started to get more supply. What can you tell us about where we are today on that front?
Yeah, so for starters, when those bars went down, I got to tell you, those were some tough times. I think anyone who's involved at the federal level or at the provincial level or at the municipal level with anything vaccine related was having a very challenging time. And of course, I know the general community was as well, because that was, you're not getting any vaccines. And basically, our pathway out of the pandemic hinges on those vaccines. So it was a pretty precarious time. But Pfizer said, they were transparent the whole time. They said, we're going to shut down or decrease production for a few weeks while we retool our plant so that we can make 2 billion doses instead of 1.3 billion doses in the 2021 calendar year. And that's exactly what happened. They slowed down for a few weeks and then they ramped back up. And now we're getting actually more vaccine than we anticipated, and we're getting it earlier than anticipated. So that's kind of where we are now. But the month of March is going to be very interesting. We're in this period of time where we're seeing a scale up of the vaccine that's delivered to Canada, but we're not really at the massive inflection point. That massive inflection point is really going to come as March turns into April, and that's when we're going to see the taps really turn on. And that's when you're going to see a massive expansion of the vaccine distribution programs from coast to coast. So, now it's being offered, for example, in maybe there's a few mass vaccine sites that are set up or clinics that are being set up to administer this. But as March turns into April, we are really going to see significantly more vaccines coming into the country, and you're going to see this profound expansion of those programs. Drive-through sites, mass vaccine sites, community centers being used as sites, pharmacies administering vaccines, primary care providers administering vaccines, and on and on and on. So I'm pretty excited about that. But of course, we have to skillfully navigate the next several months because we still need to vaccinate a significant proportion of Canadians as quickly as possible.
Right. And until those vaccines all come in, Carolyn, let me bring you back in here now, because I wonder if you can comment on this notion. There were lots of people, a lot of opposition politicians in particular, who were saying during this period of time when we were getting no vaccines in at all, they were saying, well, come on, Justin Trudeau, just pick up the phone and call some corporate executive and make them send us some. Now, I don't know how this world works, but does that kind of thing help?
I can't imagine that it would, honestly. If one phone call could procure vaccines, surely everyone would be doing that, everyone in the whole world. And maybe they are all doing that, and that's why one phone call doesn't procure vaccines. To me, I think, that delay was, obviously, as commented, very stressful for people involved in the vaccine rollout. But I think Canadians should be aware that right now, most of us are not being impacted by vaccination unless, the people who are directly impacted are the right people, the people who have been very, very vulnerable, the long-term care, the healthcare providers, the very elderly. But that's not kind of denting transmission in your community and determining whether or not, you get to go out to a restaurant or visit your friends or family, because we're not at that inflection point yet where we're doing mass vaccination. So it's actually better for all of us to have a speed up of that general rollout, even though it took a week delay in January, in my opinion, because it's that general rollout that will be critical. And also that general rollout worldwide, those 2 billion doses. COVID in Canada and our life in Canada is not an island from the rest of the world. And so as we seek to reopen borders and travel, we also need people in other places to be vaccinated and to be protected along with ourselves. Mm-hmm.
And Nick, have you picked up anything in your reporting at all that would suggest that the rather optimistic and buoyant outlook just given us by Isaac Bogosh will not come to pass? Or are you quite convinced it will?
Well, I think, there's no proof that, or there's no evidence, or there's no suggestion that delays are going to be slowed down. And the only reason we might not believe that is that slowdowns have already happened. But as Isaac said, Pfizer was pretty transparent about the reason for that slowdown. And so the government has said, the federal government, that 4 million doses of Pfizer will be in Canada by the end of March, and 2 million doses of Moderna by the end of March, and it appears they're going to achieve that. The scheduled deliveries are on track, and then the ramp up will happen, and then we'll have that wider immunization program into the summer. There's no reason to believe at this point that there will be any more major disruptions.
Okay, good. Let's do one more chart here. And this one, again, I'll ask our director, Sheldon Osman, to bring this up. This is vaccine doses administered per 100 people. And again, for those listening on podcast, I'll take us through this. You've got in the Yukon, in Nunavut, and in the Northwest Territories, very high rates at the moment, approaching 80% in some cases. In Nunavut, more than half the people have had doses administered so far. But then there is a rather significant drop-off. Prince Edward Island, 7.8%. Saskatchewan, less than 7%. Manitoba, just over 5.5%. BC, keep going. We don't get to Ontario until the fourth from the end. Fewer than 5% of Ontarians have had the shot so far. Newfoundland and Labrador, even fewer. New Brunswick, Nova Scotia, even fewer then. Okay, Isaac, come on in here and tell us about this province, of course, likes to think of itself as being a national leader in everything it does. Those numbers are a long way from being a national leader. What happened?
Yeah, so there's a few points. One is that, yes, of course, we could speed things up. And of course, there's always room to improve efficiency of vaccination. The second point is that when you look across those numbers, like the difference between, 4.8 and 4.9 or 4.8 and 5% really isn't all that much. And the third point is that direct province to province comparisons are helpful to sort of frame a discussion, but when you sort of scratch the surface, there's a lot of differences that might account for such profound, value between these. So, for example, credit where credit's due. Way to go, PEI. That's a wonderful value. But you imagine the logistics of vaccinating PEI might be a little bit different than logistics of vaccinating a massive province with 14 million people scattered all over the place in rural and urban settings. So I think those are the three key points I'd take away from a graph like that.
Well, okay, fair point. But on the other hand, the Yukon is a massive territory with a very tiny population. Nunavut, Northwest Territories, same situation. Big territories, small populations. They've somehow managed to get more than half, in some cases more than 3/4 of their population inoculated already. How come?
Well, obviously, credit where credit's due. There's nothing taking away from them for doing a wonderful job in vaccinating their population. But I think when you look at where their population is situated, many of them are in the main cities of those territories. So access is remarkable. I wouldn't say remarkably easy. It's easier to vaccinate when everyone's in one place. Of course, that's not entirely true, and I'm oversimplifying things, but that is a major component. The other is look at the volume of vaccines available per capita, and that might be a little bit different for some of the territories as it is compared to the provinces. But of course, logistics in terms of vaccinating a bulk of your population is going to be a little bit easier when everybody is within reach, rather than when you're going to have to vaccinate multiple cities, multiple towns, and even rural, remote, underserviced areas.
Okay. Nick, do you want to come in here and tell us why you think, and I take Isaac Bogosh's point that, the difference between 4.8% and 5.3% may not be all that much, but facts are facts, and the fact is Ontario apparently has the fourth worst rollout in the whole country right now in terms of comparing provinces and territories. Why would that be, in your view?
Well, I think it's worth pointing just a little bit at the territories and the reason those numbers are so high. The federal government and the provinces and territories collectively prioritize those populations for a whole lot of reasons. There are a lot of vulnerable, remote Indigenous communities. They've gone through epidemics in the past. Tuberculosis in the 20th century is one horrific example. And so those territories and the rollouts that they have executed are extremely impressive. I've talked to a whole bunch of people in Yukon, and they charter planes to communities that are 4 hours from Whitehorse, and they get 80% take-up during a 4 or 5 hour span of immunizing in that community. Old Crow is a particularly far north community. That's a fly-in place. And that community has now been 80%, as far as I've confirmed, 80% immunized. So that success kind of stands apart from the rest of the provinces. And Ontario, to speak to that complexity versus other provinces, particularly PEI, there is a lot of complexity. I mean, Ontario has its own rural and remote and Indigenous communities, and just a whole whack of people in a whole bunch of different situations. Not to excuse the effort, that number is low, and the other thing you can't do is you can't eliminate the anxiety people feel. That anxiety is real, and it's having an effect on our mental health and our lives. So to just say, well, it's tough, that's not going to be enough for anyone until it's over.
Carolyn, I wonder if you could help us understand the priority list right now, because obviously I've heard from lots of people who say, if you really want to make a dent in this thing, in COVID-19, go for congregate care settings first. So obviously long-term care, homeless shelters, prisons, that kind of thing. That's where the virus really loves to spread. On the other hand, you can imagine some people who pay taxes saying, wait a second, I pay taxes, I want to get ahead of all of that group of people. How do we resolve these competing interests here?
Yeah, so I think it's, the congregate settings is about risk, especially in long-term care. And, for better or worse, the decisions we made were not able to protect our long-term care populations. And so putting them at the very top of the priority list absolutely makes sense because of both exposure and risk of a bad outcome given exposure. The same goes for the very elderly. But after that, what we're finding is it's not so much about who pays taxes, it's about who's at risk of being exposed and being a transmitter. And I think now that we know how powerful the vaccines can be against transmission, so preventing people from getting infected, and then if they're not infected, they can't infect their contacts. What that means is we have an opportunity to get the most bang for our buck of rare, relatively scarce vaccine doses by starting to prioritize essential workers, people who cannot distance at their work. They can't work from home. They have to work in essential services, frontline work, maybe teachers, firefighters, grocery store, food production. We've, of course, seen outbreaks in food processing. These are areas where actually with one vaccination, you can prevent more bad outcomes in those groups because you prevent the bad outcome in the person you vaccinate, but also in a whole bunch of others who don't get infected because you stopped chains of transmission. So I think that's where the conversation should be turning after we finish vaccinating the very most vulnerable.
Isaac, can I get you on that? What should the priority list look like? In what order?
Yeah, great question. And clearly, there's some pretty heated debate on in media and in social media and in conversations because everyone seems to have, and rightfully so, some very strong opinions on this. I think you can approach this through a data-driven lens. You can approach this through an equity lens. You can approach this through public health lenses. And of course, the Venn diagram of those lenses overlaps at some sweet spot. I completely agree with Dr. Collane that there are strategic ways to vaccinate populations to get the most bang for the buck. I think we have to acknowledge who's at risk of death, who's at risk of having a serious outcome, and of course prioritize that. And that's equity and a public health and data-driven approach. Age is like by far the biggest risk factor, and we just can't ignore that. Now, there's a lot of risk factors for severe outcomes, but age stands above just about everything else. So we clearly have to vaccinate by age. But there's multiple right ways to do this. And for example, you've heard in Ontario, you can look at not just age, but for example, other social determinants of health that could help drive a very equitable and data-driven vaccine program. So if you look at something like postal codes, well, as it turns out, someone who's 50-year-old in certain postal codes has the same risk of dying as someone who's 80-year-old in another postal code. So if you really want to take a data-driven and equity-based approach, you can look at a variety of measures, a variety of mechanisms to vaccinate based on age, based on postal code, based on, and of course, a variety of other factors as well, like Dr. Collane mentioned, essential workers as well. So what you're going to see from coast to coast, well, I guess we're talking about Ontario. So what you're going to see in Ontario when the plan is hopefully released sooner rather than later, is that the second wave of vaccinations will be prioritizing people who are at greatest risk of having a severe outcome from the infection, but B, as Dr. Collane puts it, people that are obviously at greater risk of getting this infection, but also of facilitating transmission in the community. And of course, that does include congregate settings as well.
Great. That's a very helpful update, everybody. My thanks to Carolyn Collane, Nick Taylor-Vasey, and Isaac Bogosh for joining us on the agenda tonight. Many thanks, you three.
Thank you.
Have a good one.
Thank you.
The issue of homelessness can seem so big and so daunting, where all potential solutions, particularly during a pandemic, are futile. But tonight, we're not going to think about the massive problem of homelessness. Instead, we're going to talk about one homeless person. Her name was Margaret. Life and death on the streets is Denise Davy's contribution to understanding this issue better. And Denise joins us now from Burlington to talk about Margaret. Denise, it's great to see you again. How you doing?
I'm good. How are you?
Not too bad, thank you very much. Let's go back. I want you to take us back to the 1940s. When Margaret was born, she grew up in Barbados. What was her childhood like?
So her parents were Pentecostal missionaries who had gone to Barbados, both Canadians. They'd been assigned to Barbados to build new churches, get new members. And they arrived there in 1943, and Margaret was born less than a year later. Right from birth, she proved to be a disappointment to her father, who very much wanted a boy. And for the rest of her childhood, it was really a very rigid schedule of church, Bible schools. She ran the Sunday school class. She learned how to play piano and accordion so she could play in church. Church was a 7-day-a-week event.
And did Margaret like having the church being that large a factor in her life?
I think Margaret was very much the dutiful daughter. She really looked up to her dad, and all indications show that she really tried hard to win his approval and to be the daughter that he wanted her to be. And he was very strict and authoritarian. The kids were, spanked if they didn't behave. And the youngest brother really talked about growing up in a loveless home. It really wasn't warm and fuzzy. She really tried hard to be accepted, but I think it was quite a grueling, strict household.
And at what point did people start to notice that there was something perhaps amiss about Margaret's behavior?
So, as in many cases with mental illness, especially schizophrenia, the symptoms started to surface when she was about 15. She ran into the house one day and told her mother that she could hear her boyfriend calling her from an airplane above. She told her mother that her male teacher, was starting to have feelings for her, and that escalated. So you've got this sort of behavior to the point where she was actually like breaking windows and running around the house naked in front of her brothers. So you've got any household that would be disruptive, but a household that considers themselves role models for the community, it was highly unacceptable. So she was taken to the doctor. And on a small island back in the early 1960s, medicine and resources would have been very bare. And so that's probably why she was given electroshock treatments at the age of 15. Apparently they worked, but then their symptoms came back, and she had another round.
Well, let's talk about that, because I'm going to take it in 1962 now. I guess she's about 17 or 18 years old, and she tries to take her life. She slits her wrists. Where did that happen? Why did it happen?
So the family all of a sudden up and moved, and it was probably because of Margaret's problems. They up and moved to Galt, which is now Cambridge, probably because her mother had a sister living there. And they hoped, I think, with family support and new surroundings, that Margaret would get better, and instead she got worse. One night they heard, this is all documented in her files, they heard a peculiar scratching sound behind the door of the bathroom and opened it, and she had slashed both of her wrists. Now, in typical Margaret style, and this happened right up until she died, really, she was very flippant about it. She said that a friend had told her about it and that she just wanted to see if it hurt. So then after that, she was actually admitted to the Homewood. And after 2 admissions there, she was, they told the family, listen, just like in Barbados, we don't have the resources here for Margaret, and she needs a long-term chronic hospital like the Ontario Hospital in Hamilton.
Well, that takes us to the next part of the story, because I actually grew up about 5 minutes from what we used to call the OH back in the day, the Ontario Hospital, the psychiatric hospital on the West Mountain of Hamilton. Okay, so she's admitted there, and what happens to her while she's there?
So she would have been 18, and you could just imagine 18 years old, and suddenly you're in a hospital ward. So many unfortunate things happened to this poor young girl. Her family, within about a year, the father had already moved to the States to take French lessons. He wanted to be a French teacher. And so the mother, Verna, decided to move there with the 3 brothers, basically completely abandoning her behind, leaving her behind in Canada. After that, they rarely saw her. She rarely got letters. She was left alone to navigate the system. So the other thing that happened is that deinstitutionalization was already in full swing. And that meant they were trying to discharge psychiatric patients from hospitals in order to close beds. Margaret was one of many victims of that plan, which was a positive thing in the sense that, yes, move people into the community, let them live more productive lives, but have the supports and the supportive housing there. And that wasn't there. So they discharged her into the community within 2 years of being admitted to the hospital, so at the age of 20. And the first time she was found in a room by herself ripping up newspapers. The whole room was filled with these ripped up newspapers. And they guessed that she'd been there about a week. She hadn't eaten. She went back to the hospital. They patched her up. Within a couple of months, they tried moving her out again.
Now, we have to appreciate what the system was capable of at the time, but given everything you know about this, what would you rate as the level of care that she got when she was at the OH in Hamilton?
So inside the hospital, I mean, it likely was not the best situation. My understanding is they did have like a typing class, which she did try to participate in. She did some pottery for a while. She helped out with laundry. There were things like that, but there were a lot of things she didn't want to participate in too. I lucked out and found 2 social workers who actually were at the hospital when Margaret was there. And the one social worker set up classes to teach the patients how to take the bus and how to read a grocery flyer, how to grocery shop, all sort of trying to help them move into the community. And she said Margaret was a really angry woman and she wouldn't participate. She often liked to just lean against a wall and just smoke all day, just 2 packs of cigarettes. So it wasn't a really positive environment, but certainly the environment they put her into in the community was much worse.
Let me pick up on your comments of a few moments ago when you talked about deinstitutionalization, because in the 1960s, this became, I guess, quote unquote, the way to go. For so much of society. Essentially, the plan was, as you point out, to get people out of institutions, to get them into the community, and to try to kind of integrate them into the community as best as possible. What went wrong?
So there was 2 parts to the plan. Close the beds, and by the time it was over, within a couple of decades, they closed 80% of psychiatric hospital beds across Canada, closed the beds, and then build the mental health clinics near to where the patients were being moved. Hire social workers and caseworkers to visit people in the community. Put the supports there to help them get jobs and to rebuild a life in the community. Margaret needed a lot of intensive care, which getting the 24/7 care in the hospital, even that, like I said, she floundered and didn't like to participate in some things. To put her into an unsupervised, unregulated boarding home where the operator knew nothing about mental illness or psychiatric patients was absolutely appalling. And the outcome was predictable. So time after time, she was discharged over those years, 9, 10 times. She came back in worse shape every single time. Every single time she was more and more sick. And yet doctors would patch her up, as the social worker told me. And within sometimes weeks, she'd be back into another boarding home.
Now, when she was discharged from the Ontario hospital, where would she go? Is she living back at home? Is she living on the streets? What's her situation?
No, every time she was discharged, it was into another boarding home. They were Emerald Street, and King Street, Main Street, Lemming Street. They have the addresses in her medical files. So every single time she'd be in one of these rundown boarding homes, which, by the way, even after the 80s, when they brought in regulations and inspections of these homes, there was still problems. And today in Hamilton, these homes are still being closed down because of lack of safety and hygiene problems. So back in the 60s and 70s, they were much, much worse. So it was a gradual wearing down of her. She would go into the home, and the first thing that would happen is they give her a bus ticket to come up to the hospital and get her medication once or twice a week. And she would stop going. And she stopped going because she had a serious mental illness. It's one that she said, I'm going to rebel, or I mean, she wasn't able to function on her own. She needed a lot of supports. And so you get an operator, like I said, who's in it just for the money, and it's just a business situation for him. And then so with each time, she would start spending more and more time on the street. And finally, up until like the early 80s, she was spending a lot of time on the streets. In 72, she got pregnant. And, that was a whole other catastrophe on its own.
Do you want to go down that road right now? Because that is a fascinating part of this book, where she does get pregnant and she keeps the child. Well, she has the baby.
She wants to keep the child. She's in the hospital with, she named him Jeffrey. She's in the hospital with Jeffrey for 8 days. And then she's pretty much, she agrees finally. Her mother actually does come up from the States to convince her that she needs to give up the baby. So she does agree to do that and signs the paperwork. But all indications in her medical files show that after those 8 days, she's basically discharged onto the streets again. And so about a couple of months later, they find her in this house that the neighbors actually called, because they said there was just like five drunks, was the way that it was described, that she was living with. And she was brought by an ambulance back to the hospital again. And again, she's sickly. She's catatonic. She's covered in bruises and cuts. It clearly every sign that she wasn't capable of living in the community on her own.
Okay, let's go up to, as we might say, drone in the sky level here, and take a look at how Margaret is a piece of a much bigger puzzle. For example, I mean, there are sadly plenty of homeless people in this province and country right now. What percentage of them, do we have a good estimate as to what percentage are dealing with mental health issues?
Mm-hmm. So very good question. First off, just the whole statistics around homelessness are so hard to pin down. They have a thing called point in time, where the cities venture out and try to get sort of a count. Right now, they say in Canada, on any given night, about 35,000 people are homeless. I have to think the number is much higher than that. I'm just having been to shelters, and I mean, in Toronto alone, there's 7,000 people sleeping in shelters every night just in Toronto. So I happen to believe that it's a lot higher. And in terms of mental illness, I know the Canadian Mental Health Association said that it might be as high as 70%. And again, having been to these shelters as when I first met Margaret, I have to say it was even 80%, because the other thing that happens is that within even a couple of weeks on the street, your physical and mental health start to deteriorate. Mm-hmm. So rates of anxiety and depression are sky high among homeless people. There's a very high.
You kind of buried the lead a little bit in the middle of that answer, Denise, in as much as you did meet Margaret. Tell us the circumstances under which you first met her.
So it was 1993. I've been sitting in my newsroom for months writing stories on sort of studies and statistics on homelessness. And I said to my editor, I really think I need to put a face to this issue. I'd like to spend the night at the Wesley Center, which was known for sort of the really chronically homeless would go there. It was you get the really rundown, very ill people. So I showed up about 11 p.m. on a very cold winter night in January. And within about an hour, Margaret wandered in. And that was 27 years ago. And I still remember that moment, because I was absolutely shocked. I looked at her across the room and thought, how is this woman even walking? She was so worn down. She looked like she was at death's door. I mean, I say in my book, she reminded me of like what you think of an inmate in a Victorian workhouse or something. So I asked staff about her. They said her nickname was Princess Margaret. And the interesting thing was that she said to me, don't talk to her, because we don't think you should approach her. But she has a habit of smashing people across the face with these hard melamine coffee cups they use there. And knowing what I did about homelessness, that she'd probably been victimized, victim of violence many times. And I figured that was a defense mechanism. And I thought, if I don't hurt her, she's not going to hurt me. So I did wander over, and the amazing thing was nobody at the shelter really knew her story, even though she'd been coming for 8, 9, 10 years. And she opened up to me. She told me her whole life story. We sat and talked for 45 minutes, and my heart just broke looking at her. And I just thought, I have to tell her story.
So you're a Hamilton Spectator reporter at the time, and you go over and you befriend her and start talking to her. And this began what? What was the nature of your relationship going forward?
I mean, she died 2 years later, and over those 2 years, I saw her periodically on the street. And then there was one time at Good Shepherd Center, ladies drop in where I met up with her again. She remembered my name. She remembered that I was a reporter. I mean, she was a smart woman. So, I mean, looking back, I wish I did have more of a relationship with her. I wish I'd taken her for lunch or helped her in some way. That didn't happen, but and I'm not sure I could have helped at that point because she was just so worn down.
The scene where you describe in the book how she died is really quite heartbreaking. Denise, do you want to go through some of it? What happened on that day?
So December 6th, night of cities across Canada were honoring the Montreal Massacre anniversary. She left the Wesley Center about 4 p.m. with her friend Bob. And it would not reopen until midnight. So she knew she had 8 hours to kill. It was really snowy, cold night. She made her way east on King Street. I actually retraced her steps one night and made her way 2 hours later. So something must have happened along the way because it was only about a 15-minute walk. She made her way to the sub shop. She settled into a chair with a cup of tea. And she had this habit of she would cup the tea with her hands and let the steam come over her face to keep warm. And the staff person saw her and thought, you know what, I'm glad she's out of the cold. I'll let her rest. And customers started to complain. So she phoned the 911 and she doesn't know why she did this, but she said to the 911 people, there's a bum in our shop. We don't keep that clientele here. That type of clientele, can you please remove her? So she thinks that's why it took so long for the police to get there, because it was 5 911 calls later, and about an hour and a half, they arrived. And by that time, she had actually fallen out of her chair, and a pool of blood was around her head. They took her to the Hamilton General, which is only a 5-minute drive, and she died within about an hour of heart failure.
She had a heart attack. That's what killed her?
That's what technically on the coroner's report, but really it was, many, many years of neglect and homelessness is what killed her.
Is there any doubt in your mind that had she not been who she was, and when that 911 call was originally made, it would not have taken 5 calls to get some action?
Absolutely. I mean, when she did fall, the staffer called again and said, listen, now it's a serious medical situation. Apparently it was upgraded to a life and death call at that point, but it still took them that long. So again, I mean, her body was so run down, so much older. I say in the book, like 1 year in the streets is like a lifetime somewhere else. It was so worn down. She'd already surpassed the average age the homeless person dies in Canada is 39.
And she was how old?
She was 51 when she died.
51. That son that she gave up, Jeff, you met him, yes?
I did. 3 years after I wrote the story, I got a phone call from a woman who claimed to be engaged to Margaret's son. And I thought, this is probably not true. There wasn't enough information really in my story for this person to know that. But anyways, she convinced me to let me meet them because she said, you're his only contact with his birth mother. So I couldn't say no. They came to my house, and as soon as he walked in, I saw Margaret's face. It was, like I say, a male version, a much softer version, but the same chin, high forehead, nose. And that was quite the meeting. And I've kept in touch with him.
Now, that kid's in his 40s now. What's happened to his life?
So a couple of years after I met him, he started showing signs of mental illness. So he's had his own struggles as well, unfortunately. Not as bad as Margaret.
But the cycle continues.
Exactly.
I'm just going to ask our director, Sheldon Osmond. Sheldon, go to the top of page 4, if you would. Let's bring up this quote. This is from your book. You're quoting Charles Krauthammer, I think he was a psychiatrist as well as a great author. And he wrote, 30 years ago, if you saw a person lying helpless on the street, you ran to help him. Now you step over him. You know that he is not an accident victim. He lives there. How did this cultural shift happen in which we now view homelessness so differently from the way apparently we did half a century ago?
It's a very good question. I think it was so gradual, and along the way, there was this very convenient for the politicians attitudinal shift where we just started to blame the homeless person. I mean, my opinion of that is that the homeless have no voice. The politicians are going to answer because it's only lack of political will that the homeless problem hasn't been solved. Medicine Hat, Alberta has almost eliminated homelessness. They have the entire country of Finland, Utah. There's cities all over the Canada and the world that have solved homelessness. We know how to do it. It's not an impossible problem, and it's supportive housing and community supports. So it hasn't happened because, like I said, the homeless don't vote. They don't have a voice. And oftentimes, like Margaret, they've lost touch with their family, so their family's not about to advocate for them. But as I say in my book, there has been a lot of studies showing that to keep a person homeless on the streets for a year can cost about $100,000. And to house them and offer supports would be about $24,000. So if they're not worried about the human cost, then they should be worried about the economic costs. And then there's a lot of myths. I can't tell you how many people I've told the story, I've told Margaret's story to, and then they said, a lot of people want it. That's a choice for them. They want to live on the street. And I said, no, it's not. That's not a choice that anyone makes. You don't grow up saying, I'm going to be homeless when I grow up. It's when you've run out of all other options, and there's nothing left. So there's that misconception. And I don't think the general public knows how really sick homeless people are, that there's huge rates of, like I said, mental illness, but also diabetes, epilepsy, level 4 cancers. Dr. Stephen Huang in Toronto has done a huge amount of work on that. And he said that I think that the amount of times that they show up in the ER is about 8 times the amount that the general population. So that's where a huge chunk of the $100,000 is coming from, is because, and then they leave with antibiotics or some sort of medication, or maybe wrapping for their a cat or something, and they have no place to recover. So they don't take their medication. They get more sick. They end up in the ER in another week or so. So the attitudinal shift is because people don't know the cost. They don't know how ill people are. And also, like I said, there's this tendency to blame them, like they're lazy. And I have to say, in Margaret's medical files, and this is just one of the 869 pages of her file that I have, there were constant notes from doctors and nurses saying that Margaret's misbehaving again, and she's come back to the hospital, mismanaging her funds and trying to manipulate her way into the hospital. And I'm reading this going that she was schizophrenic. And this isn't about mismanaging her funds. She was simply not capable of doing it. And so that attitude still exists, like blame the victim.
In our last couple of minutes here, Denise, I want to focus in on Margaret and the end of her life again. She did have a funeral. Who paid for that funeral?
So I wouldn't call it a funeral by our standards, but and one thing that happened is the police didn't bother to tell anybody in the community, even though, like I said, she was so well known, they affectionately called her Princess Margaret. She was very well known. They didn't tell anybody. They hired a funeral company that did city-funded burials, and she made the lonely drive to the Woodland Cemetery one cold winter morning, about 6 days after she died, I think. And there was nobody there. I say in my book that 3,842 people died in the city of Hamilton the year Margaret died. And she was probably one of the few that had nobody waiting for her when she got there. No words were said. It was like she'd never been born. So she died a very lonely death.
Yeah, I want to ask you a very, I don't mean it to be a disrespectful question, but it's a hard question. And that is, she had a funeral, nobody showed up. Did her life matter?
Oh, well, I did. When word got out, a couple of days later, There were 25 of us standing around her gravesite saying goodbye to Margaret. And I mean, I was there December 6th, 2 months ago, saying goodbye to Margaret. Her life mattered in huge ways. And I mean, there were all kinds of calls for inquests. There were vigils. There were protests after she died. People were really, really angry. Lynn Ferris at the Wesley said, like, I can't even go to any more funerals. People keep dying. And so, I mean, I'm hoping through her book that her life matters even more, because putting a face to homelessness and certainly being able to write her whole life story like this, I hope that people will see people on the streets and say, that person has a name, there's someone's son or daughter, and their life matters. This is a brutal betrayal, really, of one of the most vulnerable groups of people in our society, and something needs to be done.
Her Name Was Margaret, Life and Death on the Streets, and it's brought Denise Davy to our studio virtually from Burlington. Denise, great job. It's a superb book, and I wish you well.
Thank you so much, Steve.
And that is the agenda for Tuesday, March the 2nd, 2021. The unspeakable toll this pandemic has taken on seniors in long-term care laid bare many additional problems in the sector. Tomorrow, we'll take a look at what we've learned and what to do about it. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.